Story number 1. Quarantine breach. I arrived at Clearwater Regional Hospital on the morning of November 9, 2023, assigned to investigate a cluster of 12 patients presenting with identical respiratory symptoms and fever of unknown origin. The facility director met me in the parking lot, visibly relieved to see someone from the state office. She explained that the local health department had already conducted preliminary interviews and found no common exposure source among the patients. The isolation ward had been established per standard outbreak protocol, with patients separated by curtain partitions and monitored in 4-hour rotations by a rotating nursing staff. I spent the first 3 hours reviewing intake documentation and environmental samples. The patients ranged in age from 19 to 62, no shared workplace, no common water source. 5 lived more than 30 miles apart. During my initial examination of patient 7, a 41-year-old male farmer, I noted his pupils were fixed at precisely 4 millimeters in both eyes, despite changes in ambient light. I documented this and moved to patient 8, a 19-year-old college student home for the weekend. Her pupils measured the same. I checked the remaining 10 patients over the next 90 minutes. All exhibited identical pupil dilation with no photoreactive response. I requested an ophthalmology consult. Doctor. Mehta, the attending physician, told me the hospital had no specialist on staff and that the nearest available consultant was in Great Falls, over 2 hours away. He suggested the finding was likely related to the fever and would resolve with the infection. By the second evening, I observed that all 12 patients had begun breathing in perfect synchronization, inhaling and exhaling at intervals of exactly 7 seconds, regardless of their individual baseline respiratory rates. I timed this across multiple observation periods using my watch. The pattern held for 40 minutes of continuous monitoring. When I brought this to the nursing staff, they acknowledged they had noticed the patient seemed calm but had not measured the intervals. The attending physician, Dr. Crace, Mehta, dismissed my documentation as coincidental pattern recognition and refused to escalate the case to regional infectious disease specialists. He stated that synchronized breathing sometimes occurred in hospital wards due to shared environmental factors such as ventilation cycles or ambient noise. I noted his refusal in my field log and contacted my supervisor by phone. She instructed me to continue observation and submit a preliminary report within 72 hours. On the third night, I entered the ward during a scheduled check and found all 12 patients sitting upright in their beds, facing the same northeastern corner, none responding to verbal stimuli. Their eyes were open. I called for the nurse on duty, who arrived within 2 minutes. She attempted to reposition patient 3, a 58-year-old woman, but the patient remained rigid, unresponsive to touch or voice. I checked vitals manually. Pulse and blood pressure were within normal ranges. Oxygen saturation was 97%. After 11 minutes, all 12 patients simultaneously lay back down and closed their eyes. I remained in the ward for another hour. No further movement occurred. I violated quarantine protocol by physically restraining patient 7 when he attempted to remove his IV line at approximately 1:15 in the morning on November 12th. He had risen from bed without triggering the motion alarm and was standing beside the IV pole, hands on the tubing, when I entered. I approached and took hold of his wrist to prevent line removal. His skin temperature had dropped to 89 degrees Fahrenheit, despite the fever readings on his chart. I verified this with a tympanic thermometer after returning him to bed. His chart indicated a recorded temperature of 101.4 degrees, taken 90 minutes prior. I checked the other patients. All showed the same discrepancy: skin cold to the touch. Chart readings indicating persistent, low-grade fever. At 2:37 in the morning on November 12th, all 12 patients simultaneously flatlined for 43 seconds before cardiac function resumed without intervention. I was seated at the nursing station completing documentation when the monitors alarmed. The nurse on duty ran into the ward. I followed. All 12 patients showed asystole on the bedside monitors. The nurse began to prepare the crash cart. I moved to patient 1 to begin chest compressions. Before I reached the bed, the monitors resumed normal sinus rhythm. I checked patient 1 manually, pulse present, strong, regular. The nurse checked 3 other patients. All had spontaneous return of cardiac function. No resuscitation had been performed. I submitted my preliminary field report with a request for specialized containment, but received orders to reclassify the incident as a resolved viral outbreak with full patient recovery. The directive came through encrypted email at 6:41 that morning from an address I did not recognize within the department's administrative domain. The message instructed me to complete discharge summaries for all 12 patients and prepare the ward for standard decontamination. I replied requesting clarification and received no response. Dr. Quest. Meta signed discharge orders for all 12 patients over the course of November 13th and 14th. I conducted exit interviews with each patient as required. None reported memory of the synchronized breathing, the postural alignment, or the cardiac event. They described a mild flu-like illness and expressed confusion about why they had been isolated. The ward was decommissioned 6 days later. All medical records were transferred to off-site storage under administrative seal, and I was reassigned to routine food safety inspections in Billings. I received no further communication regarding Clearwater Regional. My supervisor informed me during a brief phone call that the case had been closed as a cluster of viral respiratory infections of undetermined but non-reportable etiology. She thanked me for my thoroughness and reminded me that certain field observations fall outside the scope of standard epidemiological reporting. I have not returned to Clearwater Regional Hospital. The isolation ward was converted back to general medical use in early December of 2023. Story number 2, Witness 9. I arrived at the safe house outside Boise on the morning of March 7, 2024, to conduct standard intake processing for a 12-year-old witness protection placement named Michael Torrens. The property was a single-story ranch conversion set back from the county road, surrounded by flat scrubland and a chain-link perimeter. I had been assigned by the regional office to complete psychological evaluation and establish baseline behavioral protocols before permanent housing assignment. My background is in child services and crisis intervention, primarily working with minors removed from high-risk domestic situations. This was my 3rd witness protection intake that quarter. The boy had been relocated from Sacramento following his father's testimony against a distribution network. The case file indicated no prior psychiatric history, no medication, and cooperative behavior during initial transport. The safe house supervisor, a woman named Caroline Drexler, met me in the driveway and walked me through the security checklist. She mentioned that Michael had been quiet since arrival, eating meals without issue, sleeping through the night. Standard adjustment period. I met Michael in the common room just after 10 in the morning. He sat on the couch with his hands folded in his lap, looking at me when I introduced myself. He answered my questions appropriately. Yes, he understood why he was here. No, he did not feel unsafe. Yes, he missed his mother, who had been placed separately. His affect was flat but not abnormal given the circumstances. I noted his cooperation in my initial log. During that first interview, I observed him glancing repeatedly at the northwest corner of the common room where nothing was visible. The corner contained a small side table and a lamp that was not turned on. I asked if something was bothering him. He said no. I asked if he needed anything from that part of the room. He shook his head and looked back at me. I made a note but did not press further. On the second day, I observed him speaking quietly to the empty corner during his supervised recreation period. His lips were moving, and his head was tilted as though he were listening to a response. When I approached, he stopped immediately and denied having said anything. I asked who he had been talking to. He said he was talking to himself. I asked what he had been saying. He told me he was trying to remember his old address. I documented the interaction and reviewed the file again for any indication of dissociative behavior. There was none. That evening, Caroline mentioned that Michael had requested his bed be moved away from the northwest wall of his room, claiming he could hear someone breathing on the other side. She had reassured him that the room was secure and that the walls were solid, but he had insisted. She moved the bed to the opposite wall to avoid escalation. I asked if he had elaborated on what he meant by breathing. She said he described it as slow and wet, like someone with a chest cold. I made a note to address it in the next session. I reviewed the property layout and confirmed that the northwest wall of Michael's room backed onto an exterior storage shed that had been empty and locked since before his arrival. I walked the perimeter that afternoon and checked the shed myself. The door was padlocked, and the interior contained only disused furniture and stacked plastic bins. The walls were plywood over 2x4 framing. I could see daylight through gaps in the siding. There was no evidence of occupancy, animal or otherwise. On the fourth night, I was completing paperwork in the office when I heard Michael screaming. It was just after 11. I moved quickly down the hallway and found him standing outside his room in his pajamas, staring at his open doorway and refusing to go back inside. Caroline was already there, trying to calm him. He kept saying, "It was in there." He would not specify what it was. His hands were shaking and his breathing was rapid. I asked him to step into the bathroom across the hall while I checked his room. I entered his room to demonstrate it was secure. The lights were off. I turned them on and scanned the space methodically. The bed was against the east wall where Caroline had moved it. The window was closed and latched. The closet door was open and I checked inside. Nothing. I walked to the center of the room and stood still, listening. The house was silent, except for the hum of the heating system. While standing near the northwest corner, I felt a distinct temperature drop. It was localized, perhaps 3 feet in diameter, and cold enough that I could see my breath. I stepped forward, and the temperature normalized. I stepped back, and the cold returned. I held my position and remained quiet. After several seconds, I heard what resembled shallow exhalation approximately 2 feet from my position. It was rhythmic, deliberate, and did not correspond to any mechanical source I could identify. I did not speak. I stepped out of the corner, turned off the light, and exited the room. I told Caroline to keep Michael in the common area for the remainder of the night and that I would stay on site. I returned to the office and filed an expedited relocation request, citing structural concerns with the property. I did not describe the corner. I noted only that the environment was unsuitable for continued placement, and that the miner's psychological stability required immediate transfer to an alternate facility. I submitted the request at 11:43 that night. Michael was transferred to a facility in Oregon within 18 hours without standard psychological clearance. I was not assigned to accompany him. Caroline was instructed to complete the handoff, and I was told to finalize my documentation and return to the regional office. I did not conduct an exit interview with Michael. I did not return to his room. The safe house was listed for interior renovation and removed from active placement rotation. I was told the property would undergo environmental assessment and structural review, but I was not provided a timeline. My report was classified under administrative review with no follow-up interview required. I received confirmation that my assignment was closed on March 14th, and I was reassigned to a standard intake case in Twin Falls the following week. No further inquiries were made. Story number 3. The Audit. I arrived at the evidence storage facility in Culpeper County on a Tuesday morning to conduct a routine federal compliance audit of biological materials held under interstate custody agreements. The facility was a low concrete structure set back from Route 15, surrounded by chain link and access through a single manned gate. I signed in at 0800 hours and was met by the facility manager, a former state trooper named Garrett, who'd been running the site for 11 years. Garrett provided standard documentation, inventory logs, temperature records, chain of custody forms for samples transferred from county and state jurisdictions. Everything appeared in order. As we walked toward the storage wing, he mentioned that one cold storage unit had been flagged for temperature fluctuations over the previous 72 hours. The variance was minor, he said, within acceptable parameters, but protocol required notation in the audit report. I inspected Unit 7 and found all samples properly sealed and labeled, organized by case number and date of intake. The unit held biological evidence from cases spanning 3 states, blood samples, tissue specimens, swabs in sterile containers. The temperature log showed 3 brief spikes, each lasting between 4 and 6 minutes, all occurring between 2 and 4 in the morning. Garrett explained that maintenance had checked the compressor and found no mechanical fault. I documented the fluctuations and moved on to Unit 8. The door required 2 attempts to open. The handle was cold enough that I pulled my hand back instinctively. When the door finally released, the interior temperature reading showed negative 18 degrees Celsius, well within range, but the air that rolled out felt warmer than it should have. Inside, I noticed that several evidence bags on the 3rd shelf had condensation on the interior surface. I made a note and checked the corresponding log entries. All samples had been logged in correctly. All seals were intact. I asked Garrett when the unit had last been opened. He checked his tablet and said it had been 5 days prior, during a routine inventory check by one of his staff. I continued the inspection. On the 5th shelf, I found a container labeled with a case number I did not recognize. The format was correct, but the prefix did not match any jurisdiction code in my reference materials. I asked Garrett about it. He frowned and took the container down, turning it over in his hands. He said he did not remember logging it in. We returned to the office and searched the intake database. The case number did not appear. Garrett called his 2 staff members into the office. Neither of them recalled processing the container. One of them, a woman named Lena, who had worked at the facility for 6 years, said she thought she had seen it before but could not say when. I opened the container. Inside was a single glass vial, sealed with red wax containing approximately 15 milliliters of dark fluid. There was no label on the vial itself, no documentation inside the container. I asked Garrett to check the physical logs, the paper backups kept in the filing room. He left and returned 20 minutes later with nothing. I photographed the container and vial and sent a query to my regional coordinator. While I waited for a response, I continued the audit. Units 9 and 10 showed no irregularities. Unit 11 contained pharmaceutical evidence and was properly maintained. I finished the inspection by 1300 hours. My coordinator called at 14:15. She said the case number prefix had been used by a federal task force that was dissolved in 2009. She could not access archived records without submitting a formal request, which would take several days. She asked if the sample posed any immediate compliance risk. I said I did not believe so. She instructed me to complete the audit and flag the container for follow-up. I returned to Unit 8 to photograph the container in situ. When I opened the door, the vial was no longer inside the container. The container was still on the shelf where I had replaced it. The lid was still sealed. I checked the floor, the adjacent shelves, the base of the unit. Garrett and Lena helped me search. We found nothing. I reviewed the security footage. The facility had 4 cameras, one at the gate, one in the main corridor, one in the office, and one covering the entrance to the storage wing. There was no camera inside the units themselves. The corridor footage showed me entering Unit 8 at 14:32 and exiting 6 minutes later. No one else had entered the wing. Garrett suggested that I might have moved the vial without realizing it. I checked my pockets, my bag, the office desk. Lena checked the intake area. We found nothing. At 1600 hours, my coordinator called again. She said she had spoken with someone in the administrative office. She did not say who. She instructed me to complete the audit report without reference to the unidentified container and to leave the site by end of business. She said a specialized team would follow up within 48 hours. I asked if I should file an incident report. She said no. She said the matter was being handled through a separate channel. I asked what I should tell Garrett. She said to tell him that the container had been recalled for federal review and that he would receive confirmation by the end of the week. I finished the audit report and submitted it at 1700 hours. I told Garrett what I had been instructed to say. He did not ask questions. Before I left, I walked back to Unit 8 and opened it one more time. The container was gone. The shelf space where it had been was empty. I closed the door and left the facility. 2 days later, I received a brief email from an address I did not recognize. It thanked me for my cooperation and stated that the matter had been resolved. It instructed me to delete all photographs and notes related to the unidentified container. It said that no further action was required on my part. I followed the instructions. I deleted the photographs from my phone and my laptop. I shredded my handwritten notes. I did not ask my coordinator for clarification. 3 weeks later, I received my next assignment and did not return to Culpeper County. The audit was filed as complete with no significant findings. The temperature fluctuations in Unit 7 were attributed to a minor compressor delay and corrected. The incident was closed and archived under standard retention guidelines.